Hi, this is Vicky Sanderson, creator of the NP Reasoning Education blog, and today I'm going to be talking about pretest probability. Pretest probability is one of the most important core diagnostic reasoning concepts to master because it'll help you work through that clinical case appropriately, asking all the right questions. So, what we're going to do is we're going to learn how to apply pretest probability with every case that we see in practice. So, what is pretest probability? It's the likelihood a patient has a disease before any diagnostic test is performed. So, why is it important? It, number one, influences our diagnostic decision making. It affects whether further testing is needed with that patient in front of you. It helps determine which test is appropriate and what is the next appropriate action to take in this clinical case. And it also helps us interpret results based on that case that we're working through. So let's get into some examples to really illustrate what pretest probability is and how we can apply it to the case in front of us. So, first case, let's say a person's presenting with 3-day history of burning sensation when they pee and urinary frequency. They're, let's say, a female patient. They have no complicating factors like diabetes or structural abnormalities in the kidneys or bladder, etc. There's no systemic features on exams. There's no tenderness over their kidneys when you percuss or palpate. There's no fevers, tachycardia. They're stable. So you go ahead and order a point of care urinalysis, and lo and behold, it's positive for nitrates and leukocytes. At this point, with the history and exam findings and that point of care urinalysis, the most likely diagnosis is an uncomplicated urinary tract infection, right? So I asked myself, what's next? Should I send off that urinalysis to confirm those findings? Do I order a urine culture and sensitivity, or can I stop? So this is where pretest probability comes in. You are asking yourself the following 4 questions before you do anything else in this case. So number 1, what's the probability of an uncomplicated urinary tract infection? With the data and the hypothesis that I've generated so far, my pretest probability for a UTI would be high at this point. So with a high pretest probability, you've essentially reached your treatment threshold. Right? That brings us to the next question is, have I reached the treatment threshold? For this case, yes, I'm likely going to order antibiotics and do other things to manage their symptoms. Number 3, that brings us to the question of, will any more tests change my management plan? So in other words, if I send off the urinalysis to the lab or order that urine culture or sensitivity, is it really going to change the treatment? Chances are no. I'm going to be treating and targeting that UTI based on the most common bacteria that cause uncomplicated UTIs, right? And lastly, could ordering more testing do more harm than good? So possibly yes. If I'm, holding off on treatment and waiting 48 to 72 hours for that culture and sensitivity, that could bring more harm to the patient. So I like these diagrams because it gives a visual representation of, what pretest probability is and how it helps us manage that case. So for this case with the history, physical exam, and the urinalysis results alone, I've reached that treatment threshold. But let's say, at the beginning of the case when I, was just in, my history taking, I hadn't done a physical exam or urinalysis, I'd still be at that test threshold area where, my pretest probability is still low to intermediate for UTI, and I need to do more to reach that treatment threshold. And let's illustrate this again with another case. Let's say a patient's presenting, to your outpatient clinic with a 10-day history of a pretty purulent cough. They're not feeling so great. They're not toxic appearing, so you're not sending them to the emergency department. You rule out red flags like they're not coughing up blood, they're not losing weight or experiencing drenching night sweats. So, you have a low pretest probability for tuberculosis or malignancy. You do your physical exam and recognize they have a low grade fever and some crackles in their left lower lobe. Say they're not tachycardic, respiratory rate stable. So what now? Right? Am I ordering a chest X-ray? Am I ordering blood work or anything else to help increase or decrease my pretest probability? Essentially, what I'm asking again is these 4 questions. So for now, right? What's my probability, let's say, of tuberculosis? It's low. What's my pretest probability of a malignancy? It's low. Again, it's an acute purulent cough. They don't have any red flags. And now, what's my probability of pneumonia? So, they're fitting that pneumonia picture with their history and physical exam alone, right? The crackles, the low grade fever, the malaise, the fairly acute presentation of a purulent cough. So, next, I have to ask myself, have I reached the treatment threshold? My probability for pneumonia in an outpatient setting right now is probably high enough that I'm going to treat them with a duration of antibiotics. Again, third, will any test change my management plan? So, will ordering that chest x ray really change my decision to initiate antibiotics? Am I willing to wait the 24, 48 hours for that chest x ray and risk my patient deteriorating? Chances are no test is going to change my management plan. This seems like an uncomplicated pneumonia without red flags. Let's initiate the antibiotics and see if that improves their symptoms. So, fourth, again, could ordering a test do more harm than good? Right? Will ordering that chest x ray do more harm? Possibly. That exposes that patient to radiation. And if I'm going to wait to initiate antibiotics, that could risk them deteriorating in the community. So, again, these four questions just helps you reflect on your pretest probability of disease and whether you've reached that treatment threshold or whether you're still at that testing threshold where you have to keep testing your hypotheses and your diagnosis, right? So, in summary, pretest probability is integral. Understanding this concept and being able to apply it to clinical cases is a foundation for more diagnostic reasoning concepts and diagnostic testing concepts. So, again, it guides our clinical decision making. It helps us recognize what tests to order, whether more testing is needed, whether we've reached our treatment threshold, etc. All right, hoping that was helpful. Again, thank you so much for listening. More content is on the NP Reasoning Education blog. Until next time, thanks so much.